So welcome to our IC on human amniotic membrane preparation and applications. So I'm joined by Dr. Tuhin and Dr. Aditya, when we will take you through the process of how to make your own amniotic membrane. And we'll also show you surgeries on where an amniotic membrane can be used. So we do not have any financial interest in the talk. We will be mentioning some commercial products and proprietary material, but no financial interest. So this is how the course is outlined. So I'll begin with the mechanism of how an amniotic membrane actually works, and then show you videos on how to prepare your own amniotic membrane. Then Dr. Tuhin will show you how the amniotic membrane is useful in acute ocular conditions. And then Dr. Aditya will show us how the amniotic membrane can be useful for surgeries in ocular surface healing. And then two of us will again take you through some miscellaneous uses of the amniotic membrane. Dr. SOHAM BASAK will also be available for expert comments later on. So coming to a little bit of history before I begin. So it was first described in dermatology back in 1910. But the first use of in ophthalmology was in 1940 by D. Roth, who used it for a conjunctival defect. And then Sorsby and Simons used in 1940 for chemical injury. However, from 1990s, Schaefer-Seng and his group, they really catapulted the popularity of amniotic membrane. So as you can see by the timeline in PubMed by the number of publications, so there's this huge exponential increase from 1990 onwards. If you look at the basic anatomy, and if I'm not labeling this, you would mistake this to be a corneal, it's a histology of the cornea. However, this actually is what the amniotic membrane microscopically looks like. It has got an epithelium, then the basement membrane, which is collagen-wise very much similar to the cornea. Then there is a three-layered stroma, which has got the compact layer, the fibrous layer, and the outermost spongy layer. So this is where the fetus is, and this is where the maternal side is. Now, if you look at the mechanism of action of how an amniotic membrane is able to do so many variety of surgeries, so it's actually a multifactorial therapeutic action. First and foremost, it has got no to low immunogenicity. So there is very limited HLA expression on the amniotic membrane surface. Therefore, even though it's a foreign tissue, there is not much of a rejection-like reaction going on in the ocular surface. Then it's a translucent material. So this is beautiful. So the patient can see something, they can see some of their visual improvement. And best of all, we as clinicians can see the improvement of our surgery. Then there is the mechanical support and moisture retention. So it has again the ability to hydrate and store water. So any dry surface, any poorly wet ocular surface is able to retain moisture. And then chemical wise, it is very similar to that of the cornea. And then it has got this huge collection of chemokines and cellular growth factors, a real alphabet soup going on there. Name it, it's there in the amniotic membrane. And the best part is, even after a storage at -80 degrees, some of these chemical factors are actually preserved. So the amniotic membrane promotes epithelialization by going on to cellular differentiation, cell adhesion to the underlying surface, and the cellular growth factors. It has got antifibrotic properties by suppressing the TGF-beta expression, anti-inflammatory properties by inhibiting the interleukins, interferon, TNF, and FGF, anti-angiogenic properties mediated through thrombospondin, endostatins, and various metalloproteinases, and antimicrobial properties by forming a mechanical barrier itself. And then you have these lysozymes, bactericidin, beta-lysine, and transferrin. Now, the types of amniotic membrane, I'll go over more details for the preparation. So we have the freshly harvested. This when you're working in a multidisciplinary hospital. So if you have a chemical injury patient, admit it, go to the OBG department, trick a placenta, cut the amniotic membrane, and use it for surgery. Cryopreserved is when we sort of process it in the lab and we store it at -80 degrees in a tissue culture medium. Then these Lyophilized and freeze drying, they are processed a bit more where the water is, let's sort of dehydrated. And the best part is this can be stored at room temperature. However, to the best of my knowledge, this is not available in our country. So we have these commercially available. These are again lyophilized and freeze dried kinds. So Procura is the most popular one. And this is not an amniotic membrane itself, but this is by Orolab. It's an Oro amserter. So it's an amniotic membrane insertion device for quick and easy use in chemical injuries and Stevens-Johnson syndrome. And if we look at the types of the amniotic membrane surgeries, my co-instructors will be going more in details. So you have got the inlet technique. So here the amniotic membrane is cut to size, fits in like a puzzle, and it's sutured or glued to where there is the defect in the ocular surface, usually with the epithelium side up. So in the onlay or the overlay technique, we have it in the epithelium. So there's a debate going on here. So some authors describe an epithelium side down, whereas some authors go for an epithelium side up. So here the entire ocular surface, including the fornix and part of the palpebral conjunctiva, is covered with amniotic membrane. So this is more in case of chemical injury and Stevens-Johnson's. And then we have the filling in on layered technique. So this is a hybrid between the two, where layers of amniotic membrane are just piled on top of each other. So this is used to fill up tissue loss or say a small perforation. So coming to the preparation of amniotic membrane from placenta. So first and foremost, getting the placenta. So we get it from an uncomplicated elective C-section. Serology done, which is again repeated prior to the surgeries. So we already have 2 negatives for the HIV, HBV, HCV, and syphilis. And in our lab, we do a double check with the cord blood for the same. In the current scenario, a negative RT-PCR for COVID-19 is also mandatory. And ideally, it is to be prepared on the same day. So the materials, the chemical components that you need is the DMEM or the Dulbecco modified Spiegel medium, sodium bicarbonate, which acts as the buffer. Antimicrobials are penicillin, streptomycin, and amphotericin. Then the base of the media is a 1:1 ratio of reverse osmosis water or just sterilized water and glycerin. Normal saline for washing the placenta. Nitrocellulose paper as the carrier where the amniotic membrane is stuck onto. And sodium hydroxide or hydrochloric acid for pH adjustment. And the instruments that we need are a variety of graduated flasks and cylinders, a filter and pump with sterilized tubing, filter paper, pH meter, weighing scale, sterile bottles and caps, and heat seal and labels. So I'll be going through some of the videos that we have here. So we start by doing the serology from the cord blood. This is done in our microbiology lab under the laminar flow. So next, we prepared the base solution mixing the DMEM in 1:1 ratio of water and glycerin. And also we use sodium bicarbonate. This is to be maintained at pH of 7.8 plus minus 0.05. So the pH is adjusted by using the sodium hydroxide and HCl. So this is connected to the pH meter and we adjust the pH till we have a satisfactory reading. So next, once the solution is ready, we filter it using the pump mechanism to get rid of any undissolved particles or any impurities. So this is the filtering stand and this is a sterile tubing which connects to a pump. So it speeds up the process a bit. And the filter paper goes in the connecting junction here. Next comes washing of the placenta. So initially we just wash off all the blood and the clot that is clinging onto the surface. So this is done with normal saline, which is again mixed with the antibiotics, penicillin, streptomycin, and amphotericin B. And this process may be repeated twice or thrice till all the blood clot has been thoroughly cleansed. Once it is cleaned, now it's the time to harvest. So usually we get one of these cleavage planes of the amnion. This is a separation between the amnion and chorion. So once that is done, the other person sort of helps in just gently peeling the surface. And here you can see the amnion is separated from the underlying chorionic tissue. After separation, again, the amnion individually is washed thoroughly to get rid of any. And then finally, we apply these bits of cut pieces of nitrocellulose paper. So this has been cut into 3 × 3 inches. Then further, we will be stripping it down to size. So once the nitrocellulose paper has been stuck, then we take sterile scissors and then cut the amniotic membrane. Then this becomes a carrier which has got the amniotic membrane on it. So usually from a placenta, you can easily harvest about 45 to 50 pieces of amniotic membrane. Oops. So once all these nitrocellulose papers are dry enough, then we cut them into strips. So these are 2.5 × 2.5 centimeter strips. So depending on the requirement of the surgeons, you can size it accordingly. After the strips are prepared, then the culture media is bottled into sterile glass bottles. And then we put in the amniotic membrane individually. This is then sealed and labeled, and then finally stored in -80 Celsius. So along with it, what is the quality controls? We look at the culture. Blood agar and suberos dextrose is culture, and the tissues, amniotic membranes are released for surgery only once both the cultures are negative. And the logs to be maintained are a freezer temperature log and a maintenance and distribution log. This is for your quality control purposes. Thank you for your attention.